Thank you all for joining us today. My name is Sana, and I am one of the tutors at Med School Tutors. And today we're going to be talking about care management for Step 2 CK, shelf exams, and Step 3. So just to briefly introduce myself, my name is Sana. I'm a PGY2 in radiology. I've been with MSP for 4 years now, and I'm excited to have the chance to talk to you all today. And without further ado, I'll hand off to my co-host here, Dustin, who can introduce himself as well.
Hey there, everybody. I'm Dustin. I'm one of the, I'm an MST tutor. I've been tutoring with MST, I think since June of 2019, or shortly before I started residency. I'm at Emory University, and I'm in residency for internal medicine, and ultimately, hopefully, planning to become an infectious disease doctor. So really started tutoring with MST just as a passion for teaching. I really enjoy it. And I really love passing on my method of trying to do well on exams and succeed on these exams to my students. So really happy to be here with Sana tonight, and really excited to share in my view, it is my strategy for one of the most difficult categories of questions we face on our shelf exams and our step exams getting towards residency, which are these next best step in management questions. So I'm hoping to shed some light with the help of Sana and on these very difficult category of questions.
All right, awesome. So very briefly, just so you know a little bit about who we are. So we are an online tutoring company, been around for 14 plus years. We're going to talk a little bit more about who we are at the end, right before the Q&A. But we have a lot of tutors in a lot of different fields. So we are very, very excited to be teaching, and we're excited to be with you here today. So we wanted to give you a brief sort of agenda as to what we'll be covering today. So we're going to talk about the standard pathway or algorithm that most physicians use to make their management decisions. So especially as it relates to Step 2 and Step 3 and just clinical exams, talking about triage, talking about acuity, and what your sort of decision tree looks like. And we'll give you hopefully a framework to start to think about these questions. We'll talk about evidence-based practice, what actually is indicated per guidelines that have been used, observation versus management with medication versus surgery, sort of what your tree looks like. And then again, sort of like I mentioned before, we're going to try and give you a framework to sort of use this over and over again and have that thought process when you're approaching every question that's universally applicable, as opposed to memorizing a bunch of facts. And then we're going to, of course, go through a bunch of questions to hopefully give you an idea of how we use this framework and how we're going to go through all of that. And we'll also have a live Q&A at the end of our session. So if you have any questions, please feel free to throw them into the chat box, and we will either address them as we go along or address all of them at the end. All right, and with that, Dustin, how do you approach the USMLE exams?
Thank you very much. Thank you for the introduction. And I just want to highlight that you mentioned reproducibility of strategy. I think that's really important. I think when you have a certain type of question and having a method that's reproducible that you can pull out of your back pocket anytime you need it to tackle that question, I think that's really important. So my approach to the undifferentiated patient, the way I think of it, I think treatment's pretty easy. I think if you know the diagnosis, you can find a treatment. Worst case scenario is 3 a.m. You're looking it up on UpToDate, that's fine, but you need a diagnosis first. And what I mean by treatment is easy if you know the diagnosis, most of the pathologies that we've identified and commonly treat in modern medicine, there's only a handful of strategies we use to manage it, really. If you take hypertension, one of the most common widespread diseases that we see, especially in the American population, we have a handful of medications that we routinely use to treat essential hypertension in the outpatient setting, especially ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, thiazide diuretics. These are medications that, when you see it on somebody's medication list, with a few exceptions, we really know what we're treating there. So you almost the patient has a history of hypertension, look at their med list, you kind of know. So if you know the diagnosis, again, we know how to treat it. Conversely, if you look at it from the other end, like I just alluded to, when you become a resident and you're living life in the fast lane, sometimes you can look at a patient's medication list and kind of have an idea of what's going on with them, right? So you see metformin on a 60-year-old man's medication list, they're diabetic, right? Or at least they're pre-diabetic. So a lot of the medications that we use commonly these days more or less have one major, maybe two major, and then maybe a handful of minor indications. A good example of that is metformin. So the major indication that the vast majority of our metformin patients will be taking metformin for will be diabetes, non-insulin dependent diabetes. There's a minor indication for polycystic ovarian syndrome. You'll see that less frequently. So, if you know the diagnosis, again, we know the treatments, they're very frequently well established, and we know how to treat it. You got to find that diagnosis. But diagnosis is difficult. So this is especially for all the people that are watching right now, all of our students that want to do emergency medicine. That's going to be you one day. You're going to be that person. You're going to take a patient walking off the street. They can have anything. It can be life-threatening. It can be benign. It can be nothing. It can be take 2 of these and call me in the morning. Whatever the case may be, you're going to be responsible for that undifferentiated patient. We do a little bit of internal medicine. We let our emergency medicine colleagues do the most of it. So diagnosis is difficult. And I want to highlight a concept that I'm not sure is taught very well in many medical schools, and it's something that I think you get in residency, and then it kind of becomes more prescient and kind of becomes more obvious. And I want to highlight this principle of screening versus diagnostic. And when we're trying to make a diagnosis, we have screening studies that we use. An example that I will give here is somebody walks into your clinic completely asymptomatic. They just moved here from the Philippines, 2 weeks ago. They're here to get their vaccinations and get checked out. And they have no symptoms. They're not coughing, no shortness of breath, nothing like that. And you wanted to screen them for tuberculosis. Screening for tuberculosis in an asymptomatic patient would be a PPD, would be an interferon gamma release assay. If somebody walks into your clinic and they have a bloody cough, they've been losing weight, maybe they spent some time in prison a few months ago, and you're trying to diagnose an active tuberculosis infection, now we're looking at 2 completely different things. That's a screening versus a diagnostic pathway. And with somebody you think active tuberculosis, you go straight to that chest X-ray. You're trying to find those lesions, those granulomas in their lungs to diagnose active tuberculosis. You might have to admit them for sputum AFBs. But for screening and diagnosis, those are 2 very different pathways that we often go down. So it would be, I think it's poor strategy to conflate those 2 things. And then the other thing I'll say is for best practice and what is most commonly done in the American medical system. And again, if you need to be reminded, step 1, step 2, step 3, these are USMLE exams. So these are exams that kind of reflect common standard of practice in the United States and in our healthcare system. So when we talk about best practice diagnostic study, the example I give here is if you suspected a patient of having a urinary obstruction and they had an AKI on their blood work, they weren't making a lot of urine, had some flank pain, had a history of kidney stones, and you wanted to see if they maybe had some hydronephrosis in their kidneys, you could order a CT urogram. Would that show you hydronephrosis? Absolutely. Would that show you obstructive nephrolithiasis? Absolutely, it would. But I think the more appropriate screening exam for hydronephrosis and urinary obstruction would be a renal ultrasound. You can see hydronephrosis with that. It's cheaper, no radiation. So I want you to really begin thinking about, am I screening somebody for a pathology, or am I trying to definitively diagnose it? And I feel like that will actually help you moving forward, choosing between 1 or 2 answer choices.
Awesome. Yeah, that is like a perfect summary. I think the key things that I really want to reemphasize from what's been already very well articulated is the high yield things are really figuring out what that diagnostic step is, and if you have enough to diagnose, if you need more to diagnose, what sort of point in the tree that you're at. Because I think that's where a lot of people get tripped up. I know that's where I got tripped up very often. And so hopefully we'll be able to help you with that a little bit today. All right. And so as far as sorry. No, that's fine. And, I think Sana, as a radiologist, you probably see quite a bit of misordering of studies in the real world. And I know the American College of Radiology is really emphatic about, we use certain things to screen for pathologies. And if you need more information, we can go to MRI, we can go to CT, but we like to usually use ultrasounds, plain films if applicable, before we go to those more expensive and radiation, carrying exams. So to reiterate the points that I made on the previous slide, in an ideal perfect world, a screening exam would be 100% sensitive, right? So 100% of people who have X, Y, or Z pathology would be positive on your screening exam. And we'll go through some examples of that here in a minute. But in the real world, very frequently, these exams are usually not, these screening studies are often not 100% sensitive. And then even when they are very sensitive, and we use them quite frequently, they're frequently non-specific. It must be followed up with a more invasive study. And then definitive diagnostic exams, when you suspect a pathology, they've screened positive,
and you're trying to go in and actually prove that diagnosis, a definitive diagnostic exam are typically those that are more invasive, involve more radiation, and very frequently are more expensive. So let's go through some examples of screening and diagnostic studies. And this will be a mix of radiography and blood work, and some procedure here even. But I'll start with example number one, D-dimer. So D-dimer, if you remember, is a breakdown product of fibrinogen. So we think of it heuristically as being associated with thromboembolism, which could be DVTs, could be PEs, could be DIC, but despite that fact that we think of it being associated with clots and clotting, the D-dimer is very frequently elevated for a number of reasons. Really, it's kind of an acute phase reactant. We see it a lot with just nonspecific inflammation, sepsis, run-of-the-mill pneumonias, UTIs, tissue trauma, any number of things could elevate the D-dimer. So the D-dimer is a good example of a screening study because though it is very sensitive, it has a strong negative predictive value, but it doesn't really, if it's elevated, it doesn't prove a whole lot. And an example I'll give is if the D-dimer, if somebody comes in and they're tachycardic, hypotensive, and hypoxic, and you think this could be a PE, and you have a little bit of time, you get a D-dimer on their blood work, and their D-dimer is negative, the reality is that the chance of them having a PE or any clinically significant thromboembolism is very, very low. So we say that the D-dimer is a screening assay that has a very strong negative predictive value. Let's go to example number two, breast mammography. So plain breast mammography is also, you could think of it as a screening study. If a 50-year-old woman comes to you and she's ready to begin her routine screening mammograms at the age of 50, and she has no symptoms, no breast masses, no lumps, nothing's concerning her, and you order that breast mammography, if it showed a discrete mass, then that can very frequently be followed up with something more diagnostic like a breast ultrasound or even MRI if indicated. Or if it shows something like microcalcifications, that could be benign. It can also be very serious. Microcalcifications are associated with breast carcinoma. So then very frequently a quote positive breast mammogram, a plain film mammogram, would have to be followed up with another study, which could either be biopsy, it could be ultrasound. Example three, the Papa Nicolau or Pap smear. So Pap smears, we are essentially swabbing the cervical epithelium, and we're sending that to the lab, and we're having a technician stain that and look at those cells to tell us, do these cells look normal? Do they look healthy? Are their nucleoli small? Are their nucleuses or nuclei normal, not large, not overly basophilic? A lot of criteria, but essentially what we get back from a Pap smear, which is a screening exam, is abnormal cells yes or abnormal cells no. If there are abnormal cells on a Pap smear, the next step would be a colposcopy, where you actually go under a magnification and you actually take a biopsy of the cervix. And that's when you take the biopsy of the cervix, that's when you're trying to prove cervical carcinoma. Pap smear can't prove yes or no, but it can suggest there are abnormal cells present. We have to do another more invasive study. Example number four would be a right heart catheterization. So pulmonary hypertension, this very neglected disease, very hard to diagnose clinically, but if you suspect pulmonary hypertension and patients have some findings that are adding up to that, unexplained right heart dysfunction, for example, right heart catheterization would be a good example of a diagnostic exam. So when you do a right heart cath, you're going up, you're either going down the SVC or up the IVC into the right heart, the right atrium, into the right ventricle, to the pulmonary artery. And you're measuring pressures at all those different points, the right ventricular systolic pressure, the right atrial pressure, pulmonary arterial pressure, pulmonary capillary wedge pressure. And you're taking all these pressure readings to definitively prove if people have elevated right heart pressures and pressures in the pulmonary artery. So therefore, right heart catheterization is a definitive study, which is betrayed by the fact that it's expensive and it's invasive. But if you have pulmonary hypertension, a right heart catheterization will give you that answer. Example number five would be a CTA chest, and depending on your institution, it's a CTA chest, CTPE protocol, or just a CT chest with IV contrast. They go by a lot of different names, but this is the definitive exam that we use in the diagnosis of pulmonary emboli. So this is a diagnostic exam in that if there are filling defects, which is a lack of contrast in parts of the pulmonary artery, we can say pretty reliably that's probably a pulmonary embolism. So a CTA chest is exposes the patient to radiation, is expensive. It also exposes them to IV contrast, which has a risk of allergy, allergic response, and also a risk of kidney injury, theoretically. So the CTA chest is the exam you order when you know the patient has a PE and you're looking to prove it. You're looking to see how many of them are there, how big are they, and which vessels they're located in, and that can further guide therapy, actually. And the clinical pearl that I have for this slide, for step one, step two, step three, Very frequently, ultrasound is almost always a reasonable guess for as a screening diagnostic study. It's cheap, readily available, very reliable, and it disposes the patient to no radiation. Sana, do you have any thoughts about any of the radiographic things I just talked about? I know you know better than I do, but.
No, I think that's exactly right. Especially what I'll say is that often in clinical practice, what we see is not necessarily what the right test answer is.
Right.
So especially for an example of the ultrasound, right? Like the ultrasound is actually a really, really great tool. And per clinical practice, or per what the recommendations say, ultrasound is often the first line step, which is why it's a great clinical pearl. But sometimes in the ED, you'll just see CT abdomen pelvises being done, which no shade on the ED providers, because sometimes it's just, if you have a wide differential, it's easier to do that. But in terms of these questions, they'll typically give you something narrower that can often be diagnosed with ultrasound.
Sure. So the last thing I'll say, and then I'll turn it over to Sana. With diagnosis, there's this really big principle of choosing the best test. And this is especially true on the steps when they're really testing you on like what would be the standard practice, what would be the standard of care. And when you're thinking about choosing that screening study, always think to yourself, am I thinking cheap? Which diagnostic study of the answer choices available is the least expensive, the most readily available? That's very important in our healthcare system where spending is at an all-time high. Think radiation. So especially in your younger patients, think which imaging study of those provided exposes patients to the least amount of radiation. That would be very important, especially in children, young adults. This radiation from CTs really does add up, and we try to spare our patients that risk whenever possible. And think least invasive. More and more medicine, we are moving to doing the least invasive thing possible and allowing the body time to heal on its own without us getting in the way. So always think least invasive. Which diagnostic study is the least invasive to get the information I need to make a diagnosis? Sometimes if you need a biopsy, you need a biopsy, and there's no way about it. But very frequently these days with new ultrasound techniques, MRI and pathognomonic imaging findings, for instance, this is pretty true, Asana, and certain types of liver carcinoma, where we can make a pretty reliable diagnosis using MRI findings alone. So we're moving more and more away from tissue sampling, invasive procedures, and we're trying to use the least invasive method to diagnose our patient where possible. And the clinical pearl I'll have here, PET scans, positron emission tomography. I'm going to be honest with you, on steps, is seldom, if ever, the correct answer.
Yeah. I have not yet seen it be the correct answer.
Neither have I.
All right, awesome. And so, like we said, diagnosis is one of the hardest parts of this whole process. And so oftentimes what they'll ask you is a second and third order question and looking at therapies and what you need to do after you make a diagnosis. So most of the time, how we want you to think about this is, how urgent is this? Thinking about triage, thinking about the urgency of sort of these findings. Can this be dealt with outpatient? Does this need to be inpatient? Can this be done sort of, what's the acuity? And so something like many dermatologic diagnoses, psoriasis, eczema, all of those things, these are more outpatient issues. SJS, however, is not, right? So really knowing sort of the differential and knowing what the acuity of those problems could be. Other things could be life-threatening on the course of days, right? Something that would require an admission to the hospital, but not necessarily ICU level care, right? So figuring out if someone has fluid overload, if they look like they're edematous, their EF is 20%, looking at they have a history of a STEMI 5 years ago, all of that sort of clinical picture looks like a CHF exacerbation. Think, is CHF going to kill you in the next hours to minutes? Probably not, right? But CHF, untreated for a long period of time, will lead to deadly complications long-term. So again, admission, but not ICU. Hours, right? So these are the things where we think about shock, right? So all of the different types of shock. Septic is the most common form of shock. I think you probably know better than I do, but I think it's like 40 or 50% of all shock is septic shock. So always be look for those things, look for your QSOFA or SIRS, whatever criteria is a good framework for you, look for those signs whenever you see those kinds of patients, because those need to be antibiotics right away culture first, but then antibiotics pretty much right away, right? So sort of figuring out your levels there. And then minutes, in which case, do we even have time to do anything diagnostic, or do I need to act on this right now? Do I even need any imaging? Do I need any sort of anything, or do I need to treat right now, right? So for all of these, there are sort of differential steps that you can take as far as diagnosis. Psoriasis, I can wait. I can do some diagnostic stuff before I worry about it. CHF, yeah, I'll probably get an x-ray. I'll get a BNP. I'll do a bunch of other stuff. Sepsis, I'm still going to draw labs before I give antibiotics, right? Most of the time, unless they're like acutely very, very unstable, I'm probably going to get my blood cultures, try and get an idea of the white count. We'll probably have the white count in the question stem. Cardiac tamponade, however, you'll see that Beck's triad. Nothing else needs to happen. You just need to go straight into procedure, intervene, get the fluid out of there. So sort of figuring out the acuity and going from there.
Also, like how you pointed out, and this will be more important for thinking about step 3, is something that we don't think about a lot as medical students until we become residents. But like, not only how severe and how life-threatening is what I'm treating, but what is the setting that I'm treating it in? And on step 3, when a patient walks into your clinic, and then you have to say, send to ED, send to ICU, whatever the case may be, you really have to think about what is the most appropriate setting in which this patient is receiving care. And that's very important, both on the test and in the real world. So.
Absolutely. All right. And so sort of similar idea as what we were talking about before. It's all about acuity, right? So we really want to hammer home it's about acuity. So when do you treat, and figuring out the what to do to treat. Most of those things are going to come pretty naturally as you study. Really, it's about like, how soon do I need to do this? Do I have time to do something else, or do I need to do this right away? So going through some examples, we'll talk about which of these are more urgent and which of these are a little less so. So as you guys are looking through some of these, so I'll tell you more than one of these are non-urgent. So if you see any of these that look non-urgent to you, please feel free to throw in the chat which ones you think are urgent and which ones you think are non-urgent, right? So I'll start with sort of the first one, umbilical cord prolapse, right? So umbilical cord prolapse, you can think of as, well, I'll just say this is an OBGYN emergency, right? I'll leave it at that because I know less about it than the OBs certainly do. But the umbilical cord prolapse suggests to you that the cervix is no longer completely patent. And I don't even know if patent is the right word. I'm trying to think of what the word is.
There's already been ruptured membranes, and now the cervical os is dilated enough to where we're not holding everything
dilated.
in.
Yes,
Right.
It's dilated, and so you no longer have that barrier, and so basically movement is starting to happen, and so that's an emergency, needs to be acted on right away, right? Immediate intervention. Abnormal uterine bleeding a lot of people are already talking about this. So abnormal uterine bleeding in a post-menopausal woman, right? So a woman, 60 plus years old, she's having some abnormal uterine bleeding. So I'll say with a caveat here, how much is she bleeding, right? Are her vitals stable? Is her H&H stable? Is she having any like manifestations of like really low blood counts as a result of this bleeding? If not, it can probably wait, right? Unless she's having literal hemorrhagic shock from this bleeding, it can probably wait and be dealt with in the outpatient setting. This is not something that needs to be acted on right away. So you can do some workup. You can do, a transvaginal ultrasound. If you need to do a biopsy, you could do like an endometrial biopsy, really go down, and the history will give you more as to, which pathway to go down for this. But again, just, is there shock involved? Does this need to be dealt with now? If not, outpatient. Another one, we have systolic murmur, cardiac apex, asymptomatic young patient. So I think that the key here is asymptomatic young patient. So that should give you a hint as to the direction we're going in. And also a systolic murmur, right? So you may remember from step 1, diastolic murmurs are always pathologic, right? Diastolic murmurs, always pathologic, always something wrong. Systolic murmurs can mean there's something wrong, absolutely, but they also could be a fairly benign entity, right? You could just have like mitral valve prolapse, for example, right? So certainly you can work out in the outpatient setting, get an echo, do what you need to do, unless they're having episodes of syncope, unless they'll give you sort of like warning signs, right? For any of these. So like for example 2, hemorrhagic shock, right? For example 3, sort of cardiogenic shock. So they'll give you these signs to suggest more urgency, but if there are none of those signs, move forward with outpatient, do more diagnostic stuff. And then, for example 4, chest pain, EKG, ST elevations. So this is our classic ACS, right? Classic STEMI. And so this is urgent, right? You are having active ischemia of the coronaries, of the heart tissue. So this needs immediate intervention. Something needs to happen now. They need to go for probably a CAF, but certainly certainly need to be worked up further in the inpatient setting. And then penetrating abdominal trauma, positive fast exam, hypotension, right? So penetrating trauma in general, even without those things, I'd be like, oh, I don't feel super comfortable managing that in the outpatient setting. But positive fast exam, what that implies is fluid in the abdomen, right? That implies that you are bleeding or something. So fluid is collecting in the abdomen. You have fluid that should not be there. And then on top of that, hypotension. So this just suggests to me shock, right? If you have low blood pressures, think about shock, think about shock, think about shock. So this is, again, urgent, needs surgery, needs to have some sort of procedure, probably an SLAP, to sort of have that worked up. So overall, 2 and 3, unless they give you signs of shock, probably can be worked up in the outpatient setting. The rest of these, more inpatient care, more acute, needs more active interventions done. And so I think the key pearl from this is really trying to figure out, it's very easy to say, well, I'm not 100% positive that that's what the answer is, so I could do another diagnostic test to prove it. But really figuring out, is this urgent, and do I need to just deal with this now, or do I actually need another diagnostic test? That's often the sort of algorithm that they have you pick in. So really try and figure out what the urgency is. All right, and then strategy.
So I've done a lot of thinking about this really difficult category question, next best step in management. It haunted my nightmares when I was a third-year student.
Yeah.
And it's one of the most frustrating ones, because I very frequently felt like, as I was taking step 2 or step 3, I was like, do they think I'm a resident already? Do I think so? I feel like these questions kind of take on a stature that precedes them. And I've thought a lot about them. And when I've been teaching my own students, I've noticed an algorithm that I kind of slowly, condensed over time, that I think is helpful. I think it's beneficial. And my goal with this, will it fit all questions? Maybe not, but I feel like this fits the vast majority of those next best step in management questions you'll have. And my goal that we alluded to very early in the presentation is that I really want you to have a reproducible way to approach questions. You should be approaching similar questions in a similar way to get similar outcomes, which is the correct answer. So starting with strategy. So the first step the first branch point we have here, acuity of illness. Now, we've harped on this quite a bit already, but this is one of the really important things in medicine, is identifying a patient who is acutely ill. And that is the patient who we should be most invested in intervening upon early. So let's talk about acuity of illness. If you have a patient in front of you who is acutely ill, and they have what you perceive to be, based off of vital signs, physical exam findings, history, what is an imminently life-threatening pathology. That could be cardiac tamponade, that could be a massive pulmonary embolism, that could be acute coronary syndrome with a STEMI, whatever the case may be. If you identify immediately an imminently life-threatening pathology, even with the clinical data you have, just meeting the patient for the first time, you have to perform life-sustaining therapy immediately. And the example I'll give that we talked about earlier, Sana, is cardiac tamponade. So cardiac tamponade, Beck's triad, muffled heart sounds, hypotension, distended neck veins. You got to act right away. So you're going to get an ultrasound of that chest, you're going to get a needle in your hand, and you're going to go for it, and you're going to drain that pericardial cavity and potentially spare that patient's life. So that is an example where you can make a diagnosis, and very frequently in the question stem, they will give you enough information to make a clinical diagnosis. Very frequently, these will be the imminently life-threatening ones, where the next best step, the standard of care, is urgent intervention without further diagnostic tests or studies. So let's back up to the top of this tree again, starting with acuity of illness. So we have a patient in front of us who we see if they have a problem, they have a pathology, they have something abnormal about them, but it does not appear to be imminently life-threatening that we can identify right now. And of course, that can change. Patients can change over time, but on a question stem, it'll be a patient in front of you, not in imminent life-threatening danger. So the question is, do we know the diagnosis? If no, the diagnosis is unclear and they're stable, that tells us that we have time to pursue that diagnostic intervention. We can do blood work, EKGs, radiology, whatever we need to help secure that diagnosis, or at least make us more sure of the correct diagnosis. And again, like I said earlier, if you know the diagnosis, you can treat it. So let's back one step up. We go from, 2 steps up. Let's go to acuity of illness again. We have a patient in front of us, again, doesn't appear in imminent life-threatening danger. When the diagnosis is clear, I walk in. Remember, a congestive heart failure exacerbation, this is one of the most common pathologies in internal medicine. I've seen way more cases than I'd like to mention at Emory University. So This is, we often forget that CHF exacerbation is an entirely clinical diagnosis. CHF, congestive heart failure, is actually a clinical syndrome. It is a syndrome it's a diagnosis made using your hands, your eyes, and your ears. So I walk into this room, I hear crackles in the lungs, I see jugular venous distension to the angle of the mandible. I have 2+ pitting edema all the way up to the thighs. They're short of breath. They've just been going on for a little bit. I'm thinking CHF exacerbation. So if the diagnosis is clear, I can go ahead and begin therapy, which in this case would be IV diuretics. In the real world, we're going to get the chest x-ray and the blood work and everything else. That's fine. But for a question stem, when they're giving you a clinical diagnosis, then if the diagnosis is clinical and you know the answer and they're not in imminent life-threatening danger, then you could initiate that next best step in therapy. And as I allude to down here at the very bottom with this next clinical pearl, keep in mind that very often the next best step in management for a stable pathology would be observation and continued monitoring.
Yep. Awesome. Awesome. All right. And so with that, we're going to get into some practice questions, and we're going to talk through that exact same framework that Dustin went through as we approach each of these questions. So you'll have a sort of sense of seeing it in practice and seeing how we approach these questions. So as I'm going to read along and sort of walk you through my thought process and how I approach this question. And for any of you who are reading along with me, please feel free to throw your answers out there. Let us know what you're thinking, and then we'll sort of address what we think and what sort of tricks and tips to avoid. So 24-year-old woman, okay, young woman, presenting to the ED department or the emergency department with 6-hour history of acute shortness of breath. Okay, so sudden onset, 24, very young. So I'm sort of thinking that this is just a sudden process and acute onset. Let's see what her vitals look like, but I'm starting to think, okay, how stable is she? Yesterday, she returned home from vacation after a 10-hour car ride. Okay, so 10-hour car ride, boom. What am I already thinking about? Some people, feel free to throw out there, 10-hour car ride, prolonged period of immobility. A lot of people are already saying it. So pulmonary embolism, exactly, right? So acute onset shortness of breath after a period of immobility, always think about PE. So excellent. This is already in my mind. She takes oral contraceptive pills daily. Okay, further solidifying for me, yes, PE. This makes sense. I feel good about this. Okay, while in the emergency department, she has a syncopal episode, which, okay, now I'm a little bit nervous about her stability. Syncopal episode while walking to the bathroom. Her temperature is 37, okay, fine. Blood pressure is 92/64. Little low, but she's 24, so I don't know what to make of that yet. So I'm gonna keep going. Heart rate is 134, so that's definitely elevated. Respiratory rate is 26, so we're looking at respiratory distress. And oxygen saturation is 87. Okay, so she's looking pretty sick to me, right? Like her vitals are not within the normal range. She just had a syncopal episode, which makes me think that she really is not compensating well. So I'm really worried about an acute PE in this patient. And I'm worried that she's going to decompensate fairly quickly because she literally just fainted. So physical exam, clear lungs, regular tachycardia. Okay, that all fits with PE, right? You wouldn't expect to hear anything on clear as far as lung sounds. And tachycardia, sinus tach, classic for PE, right? Which of the following is the next best step in management? Okay, so of course, it's not going to say what's the diagnosis, right? So we feel comfortable this is a PE. I feel pretty confident it's a PE. The real question is, do I need something else? Do I need to prove this to myself? Do I need to do anything? And what I will submit to you here is the first question you actually need to ask yourself is, how sick is she? What is her acuity? Is she actively going to decompensate, or is she stable? And I would argue that she looks pretty sick. She's fainting. Her vitals are all over the place. Her oxygen sat's 87. She's 24. So she looks very sick. So I want to do something about this now. So just based on that alone, that gets rid of A, right? That gets rid of B. That's another diagnostic. Rivaroxaban, okay, that's a treatment. CT, get rid of that. That's also a diagnostic, right? So now we're at C and E. And so what I'll say is this is more about knowing the nuances of treating PEs. But when you have someone come into the emergency department, it's always continuous heparin, right? You start off with continuous heparin infusion. And if she were stable, it would be reasonable to consider the CTA, right? It would be reasonable. The D-dimer less so, because you could do the whole well score and think about, if D-dimer is more for people with low probability. Chest x-ray, honestly, if a person came in with shortness of breath, they would probably get a chest x-ray, but that's not the appropriate first step in this patient, right? So as many of you accurately said, heparin is the first line step here. And so going through sort of my thought process, this algorithm, exactly like what we were talking about before, very beginning, acuity of illness. How sick is she? Is this life-threatening? And we decided pretty quickly that it was, right? And the first steps for you in looking at that is look at the vitals. The vitals are called vitals for a reason, right? So the vitals will tell you if this is life-threatening. So based on that alone, okay, I'm going to treat her. And then, you know, figuring out the specifics of what treatment is the best choice for her are really more specific to the disease processes, right? So we certainly want you to focus and memorize on all of those. But for the purposes of sort of working through these questions, that's sort of that first branch point. And so just sort of another clinical pearl. So massive PEs depend, and most centers have sort of like PE teams it's like a multidisciplinary team with like cardiology, vascular medicine, sometimes IR gets involved. They can have like injected thrombolysis, they can get like directed TPA, they can get mechanical thrombectomy, etc. All of that is well and good, and maybe she would be a candidate for that. But the first step is get her anticoagulated. That is always going to be your first step as far as these pathways go. Anything to add on that, Dustin? Yeah.
I like your statement about the vital signs being vital, which you definitely did take my line, because that's not my favorite line for medical students. But no, so in my experience in internal medicine, if you listen to the patient, they will tell you the diagnosis, and they will tell you when they're in need of help. And vital signs are the way our body raises those flags to us. Abnormal vital signs are, especially if they're abnormal in the wrong direction, hypotension, for instance, rather than hypertension. Abnormal vital signs should always give you second pause, should really make you think about that patient, what can be going on, and what I need to do to help. So. Yep,
absolutely. All right, question 2.
So now on the opposite end of the spectrum, if that gives you any indication of where we're headed. I will say for the last question, it's always nice for the patients to read the textbook, but sometimes they forget to, so they present in unusual ways. But that was pretty textbook. Great. Question 2. So I think it's always a good idea to focus on test taking strategy. It's always a good time to talk about test taking strategy. I'll talk a little bit about it here before we get into this question. I'm a little bit old fashioned. I start at the top and I read to the bottom. And some people will read the interrogative, which in this case, the interrogative is which of the following is the next best step in management. I think that's fair. I think that's reasonable. Some people read answer choices first. I think that's reasonable, but sometimes I think you can pre-suggest yourself. I'm a little bit old fashioned. I like to start at the top and read to the bottom. So let's do that now and let's see what we think. I have a 3-month-old infant brought to my clinic for a well child examination. He makes 6 wet diapers per day and cries for the bottle every 2 hours. So far sounding pretty normal. He is at the 78th percentile for height, the 70th percentile for weight, and appears well-developed and well-nourished. Again, seems like a pretty healthy child. His parents point out a periumbilical lesion that has been present and has been even increased in size since his birth. And we see that in the attached photo. Which of the following is the next best step in management? So as I think about this, and I'm thinking through our algorithm here, the next best step in management question, I'm going to try to approach this in a reproducible way. I'm going to go back to our algorithm and I'm going to start at the top. Do I think that this well-appearing child who is growing appropriately, is putting on weight appropriately, is making an adequate amount of urine, it seems like each day, and is eating about 2 hours, which is appropriate for somebody this age? Does all that seem normal to me? Absolutely. So now I'm thinking, is this person in acute life-threatening distress? Is this 3-month-old infant in life-threatening distress? I'll probably say no, right? So now I'm going down that right side of the pathway. If you can remember in your mind's eye, we're going down the right side there. So now the question is, do I have a diagnosis here? I think I do. And then based off that diagnosis, what do I need to do to treat it? And again, remembering our ace in the hole that we can always pull out of our back pocket if we need it, continued observation. So let's go through these answer choices. Again, thinking about test taking strategy and really thinking about striking out answers. I'm a really big proponent. I'm a strikeout queen. Ask any of my students. I strike out everything that's wrong. If it's wrong, strike it out. If you strike it out, your brain never has to think about it again. And that's the way to do it. So going through this, starting with A, punch biopsy of the lesion. If I'm looking at this, I think this is pretty characteristic. I think I know what's going on. Do I need to biopsy that? Probably not. And if it's made out of what I think it's made out of, there might be a lot of bleeding involved. I don't think I want to go there. MRI of the brain. So I think this is kind of thinking back to step 1 and kind of the reptilian parts of your brain, thinking about all those neurophicomatoses, neurofibromatosis 1, neurofibromatosis 2, Sturge-Weber syndrome, and thinking about all those different kind of esoteric syndromes and a lot of dermatologic findings, a brain finding, thinking skin and brain. Am I linking those two here? This doesn't look like something I associate with the cafe au lait spots of NF2 or anything like that. So I'm less likely to go there at this point. So MRI of the brain, I don't think I need to go there yet. Excisional surgical biopsy of the lesion. Again, I'm thinking invasive. Do I want to go there? Do I think this needs to be removed if it's been there since birth and doesn't seem to have affected the health of this infant at all? I don't think I'm going to go there yet. I'll strike that out. Continued observation and reassurance. Well, if this looks like what I think it is, and I don't think it's life-threatening, so I think it's not life-threatening. I think I've made a diagnosis. Now I'm thinking about the next best step in therapy. And I'm thinking my therapy ought to be pretty conservative here. So I'm going to keep D on my mind here. And then looking at a topical cobalamin cream, a steroid for this. Looking at it here, it doesn't have that typical inflammatory scaly appearance. Is something that I would typically throw a steroid at. Psoriasis, different types of rashes associated with autoimmunity. All those things would be pretty unusual in somebody this age anyway, 3 months old. So I think I'm going to have to go with D. And I think the diagnosis here is a strawberry, or also known as a capillary hemangioma. So if we look at our strategy here, and I kind of walk through this again, think about acuity of illness. I have a well-looking child. That's one of the most important parts of your physical exam. From the doorway, you look at your patient. Do they look well to you? And if they do, that's reassuring. If they don't, you need to act fast. This is a well-appearing infant. It's got something that's been going on for a little bit now. I take a look at it. So I don't think it's imminently life-threatening. He looks like he's doing pretty well. He's 3 months old. He's growing. He's putting on weight. It's all good. I think I know the diagnosis. The diagnosis, I would say, is clinical in this case. So I'm going to go down the very far right side of here, and I'm going to order my first-line therapy. And my first-line therapy is observation. So the clinical pearl I have here, capillary, or kind of colloquially known as strawberry hemangiomas because of their color, are very frequently, most often benign, and they often grow somewhat in the first 2 to 3 years of life before regressing completely. If I recall correctly from my pediatric days, by 5 or 6 years of age, they usually regress completely. So,
awesome. All right, moving right along. Another case here. So, next one we have is a 38-year-old man. Okay, so fairly young, and brought to the emergency department following a high-speed motor vehicle accident. Okay, so I'm already thinking down my trauma pathway, right? Blunt force, penetrating, hard to know, we'll keep thinking. Upon arrival to the trauma bay, he is alert and in visible distress. There is a large bruise across the right chest and abdomen. Okay, so right chest and abdomen. So they specify side for the chest. So this is something that's very, you just know it when you know it. They're talking about the seatbelt sign, right? So right chest, abdomen. Okay, big bruise. Visible or vital signs reveal a blood pressure of 82/58. Okay, so vital signs vital. Very hypotensive. Heart rate of 148. Okay, I'm worried. Respiratory rate of 36. Okay, I'm super worried. Breath sounds are absent on the right side of the chest. Okay, so this is the first piece of information that's really telling me, okay, now I have an idea of what's going on. Because the vital signs alone don't tell you what specific pathology is going on. Is he in hemorrhagic shock? Is he in septic shock? I don't really know. I just know that he's hypotensive and he's tachycardic. The respiratory rate does give you a hint, right? Because that suggests to me that there's some sort of lung pathology going on. But the breath sounds being absent on one side of the chest should make you think about something right away. Is there anything specific? Some people are already putting it out there. Excellent, excellent. What do you think about no breath sounds on one side? Good. So a lot of people are saying pneumothorax, right? So absence of lung sounds on one side, JVD. Okay, so that further supports this. So the pathology for JVD, think about sort of this compressive force on the jugular venous system and the venous return to the heart, right? So that's leading to all of this backup because the heart is not able to accept the return of the blood. And then what is the next best step? Okay, so again, we already have this diagnosis of pneumothorax in our head, right? We feel pretty comfortable that this is a pneumothorax. The first question I would ask you is tension or not tension, right? And this patient looks very unstable to me. His vitals are all over the place. His clinical exam looks concerning. So that, and it literally says he's in visible distress. So all of those things, he's very sick. So probably a tension pneumothorax. So because he is very sick, do we have time for diagnostics? No, right? So cross out anything that has anything to do with diagnosis. Chest x-ray, no thank you. And then needle thoracostomy, we'll come back to that. CPR, we'll come back to that. Fast, no time for diagnostics. Intubation, mechanical ventilation, we'll come back to that. Okay, so now we are looking at needle, CPR, and intubation, right? So do we need to do CPR here? No, right? Because this patient has a pulse, right? He has a pulse, he has a heart rate, he's still alert and oriented. He is in distress, absolutely. But CPR, clinical indication for CPR is loss of pulse, right? Always check for pulse. So nope, he's got a pulse, he's got a heart rate, no need for that. So needle versus intubation, right? Pneumothorax can actually be very, very simply treated with just a needle thoracostomy. So in this case, that is the correct answer, and that a needle thoracostomy would treat this patient. So here is the chest x-ray for a patient that may have been this patient. What I'll say is you can look at this and forgive me, but I'm nerding out a little bit. So you see here this sort of pleural line, right? And you see a complete absence of lung markings in this whole area here. So absent lung markings, see the pleural line, that suggests you pneumothorax. But clinical pleural being, this x-ray you do not need to solve this question, right? They might even give you this x-ray in the question stem, but you didn't need it. You didn't need this to A, to diagnose it, and B, in terms of clinical management, shouldn't have even gotten it because you can diagnose based on the clinical story and the clinical exam alone. So again, what you see in clinical practice on day-to-day, on third year, fourth year, during your rotations is not always what the answer is. So trust, do I actually know what this is? And sort of going from there. Awesome. All right. So yes, exactly like I said, acuity, he was very sick, right? Vitals were all over the place. And so we need to treat, right? No sort of diagnostic stuff, just like we ruled out the any sort of imaging, we ruled out any sort of ultrasounds. And so first step for pneumothorax, clinical pearl for this one, is needle decompression, and you will eventually have a chest tube, but needle decompression comes first because it's quick, it's easy, and it can be done very quickly and provide immediate relief. All right. And question 4.
All right, so coming in to finish this up here with question 4. So again, I'll say again, I'm old-fashioned. Let's start from the top. Let's just read down. 64-year-old woman with hypertension and diabetes, setting the scene here, is brought to the emergency department via ambulance 45 minutes after the acute onset of numbness and paralysis of the left upper and lower extremities. All right, so thinking in terms of localization in the neurologic system, this is the 100-year-old neurology attending that you rounded with that always harped on localization. They did it because it's important, and it helps us track down what are the therapies that are going to be available to us to treat this patient, and what is even the array of differentials we have to think about in a patient who's localizing to the peripheral nerves, the spine, the brain, where within the brain. Is in the brain stem, is in the cortex. So you can kind of help guide your differential and thus your management by kind of localizing, even in a gross fashion, just kind of, from kind of eyeballing it from across the room. Where's that lesion at in the neurologic system? So the sudden onset of paralysis and numbness left upper and lower extremities. She has headache or visual changes. That tells us a little bit something about what's going on in the cranium. Her vital signs reveal a blood pressure of 162 over 85 millimeters of mercury. Physical examination reveals absent strength and decreased sensation in the distal and proximal left upper and lower extremities. So the entire limb seems to be involved. It involves half of the body. So if I'm thinking backwards, I don't think this is peripheral. I have a lower suspicion of it being due to the acuity onset. I'm not getting a trauma history here. Less likely to be a hemichord syndrome like Brown's-Sick heart or something like that. And we're not hearing about loss of temperature sensation on the contralateral side of the body, but I'm really thinking this is going to be intracranial. And there's the most common neurologic problem in the United States that I feel like is going to be an issue here. Her pupils are symmetric and reactive to light. Her serum chemistry is unremarkable. Her A1C from a month ago was 8.1%. Which of the following is the next best step in management? So if I go back and look at this question, this person has the acute onset of a neurologic deficit. So this is actually meeting the diagnosis of a syndrome, a clinical syndrome, that we colloquially, and I guess in the formal medical literature as well, refer to as stroke. So if I think of this patient has a stroke, for all my buddy neurologists out here, or out there in the audience tonight, I have to say there's really only one good therapy we have moving forward here. Okay, so we want to get them to that best therapy being TPA, tissue plasminogen activator. We want to bust up that clot that's in their brain, and we want to open the circulation back up, time his brain. We want to preserve as many neurons as possible to give this patient the best functional outcome possible. There's only one way we can get them to that therapy. We got to get them there. So let's look at our answer choices here. So A, non-contrasted computed tomography scan of the head, so a non-con CT of the head. B, recombinant tissue plasminogen activator infusion. C, labetalol continuous infusion. D, intravenous carbamazepine. E, nerve conduction studies of the upper and lower extremities. And F, lumbar puncture followed by intravenous antibiotics. So when I'm thinking through this, I'm thinking, is this patient in imminent life-threatening danger? Well, potentially. And there's actually the most dangerous form of stroke. When you think about stroke, thinking back to your step 1 days, you're thinking ischemic stroke and hemorrhagic stroke. The good therapy that we have for ischemic stroke, which is by far and away the most common kind, and we could talk about thrombotic and embolic strokes, we can talk about that later. But as of right now, let's think about ischemic and hemorrhagic. The therapy we have for stroke is TPA. In order to get them there, we have to prove to ourselves that there's no bleeding in the brain. So you're just kind of thinking through, what do I think this is? What can I do for them? And the good therapy that we have, how do I get the patient there? I need to know about intracranial bleeding. If there's any intracranial bleeding, TPA would be contraindicated and would actually jeopardize the patient's life imminently if it was given. So then I have to think about, how can I prove or disprove bleeding in the head? And one of the actually quite sensitive exams that we have that can be done pretty rapidly in most stroke centers these days is a non-contrasted CT scan of the head. So I'm going to think answer choice A. We could talk very briefly about why, if we look at this pathway here, at our strategy, I'm thinking acuity of illness. Do I think this patient has an imminently life-threatening pathology? As far as I can see right now, not being hypotensive, not having asymmetric pupils, not having a headache, not being confused. Confusion in the setting of a stroke, I mean, while possible in some frontal lobe strokes, sure, would also be a warning sign that maybe there's something mass occupying happening in the cranium, such as a bleed. So in the absence of those things, I think this patient's doing okay right now. And I want to get them, and the diagnosis is unclear. And I just want to emphasize the fact that in this case, truly the diagnosis is unclear. We made the clinical diagnosis of stroke, but we haven't refined that to ischemic or hemorrhagic stroke. And in order to actually formalize that diagnosis, I need that CT scan of the head, and I need it right away. So let's say if we look down our pathway here, beginning with acute illness, not life-threatening as far as I can see right now, need to work this up. Do I know a diagnosis? I don't. And actually that diagnostic information is what I need to make a management decision, which is TPA, yes or no. So I'm going to order the best diagnostic study. And for somebody presenting with a syndrome consistent with stroke, that first diagnostic study you got to do is a non-contrasted CT scan of the head. And as I give the clinical pearl down here, it is necessary to exclude hemorrhagic stroke before giving TPA. Sonia, do you have any different thoughts about this? I know in stroke, if you get to the nitty gritty of it as a radiologist, you're probably reading a lot of CTAs or MRAs, whichever your institution is doing. And I think in the longer term, that kind of guides us. Do antiplatelet therapy, yes or no? But in the setting of an acute stroke, I think the best next step would be the CT scan.
Absolutely. And most of these, most clinical centers have sort of like a stroke package, which means they'll get like a non-con head CT, and then they'll do like the CTA of the brain and the neck to look for sort of vasculature. At Brigham, for example, we do CTA head and CTA of the neck veins. We don't typically do MRA for an acute stroke, but everyone sort of varies from institution to institution. But those other things are really for any sort of mechanical possible intervention, right? So the angio is to look for, is there something that interventional neuroradiology can do a thrombectomy on? Is there sort of a carotid endarterectomy target? Which is important, absolutely. But the most important thing is, can we reverse this right now? And that will be determined by the non-con head CT, which will sort of tell you blood, no blood, sort of go from
TPA,
there.
yes or no? Yep, that's it. That's
Exactly.
important.
All right. Awesome. So that is sort of what we had as far as questions today. So if anyone has any sort of questions, and I know we've got a couple that we're going to definitely address during the live Q&A portion right after this, so please feel free to send them in. I'm just going to briefly, while we're waiting for questions to come in, touch upon who we are at MST and what we do. So as I mentioned before, I've been around 14 plus years, lots of one-on-one tutoring with people who have graduated from every medical school across the country, across the world, and who have ended up in every specialty in every part of the country. So a very, very diverse group of tutors. And we all have very different strengths and sort of talents and passions surrounding teaching. So, you know, our team sort of pairs us up based on what your needs are and what your tutor styles are, and really helps to customize your tutoring, really give you a guided schedule, and help to maximize how you can perform on your exams and in school overall. We also have residency and ERAS counseling, and sort of guidance for the application process to residency, and also just one-time strategic sessions for people who are interested in just getting a sense of what they need to strengthen in their applications or what they need to focus on while embarking on the step studying process. So we have a lot of great people, and we are very happy to be in touch with anyone if you guys have any questions. So with that, one question I saw that was really excellent, which I'd love to get your thoughts on, Dustin. So if you know the right answer, do you need to read through the rest of the answer choices? If you just know it, like right away, once you read it off the bat, what's your typical strategy? What do you tell your students?
That's a really good question. One of the reasons I don't have students read the answer choices first is because I think if you read the answer choices first, and one of them, for any number of reasons in your brain that you can't explain, sticks out to you. So like the CHF exacerbation looks really good to you right now. And you go back, you start reading the question stem, then everything you're reading that question stem will begin to fit into your thought process of CHF exacerbation. So you will make the fever fit in. You will do it. You know, your brain will make it happen. So when you're reading through, I'll read from the top to the bottom. I get to my answer choices. I'm reading through. Even if I see the one that I know is correct, you know, I feel good about it. I feel like, you know, it's really nice when you think of an answer choice that you didn't even see down there first, and then you get to, I was like, oh, answer choice C is exactly what I was thinking of. You can usually feel pretty good that's the right answer. What I will say, how do I put this? I guess related to that question, that, you know, if you know it right away, read the rest of them. If none of them fit, and you know that answer choice, you thought of it before you even saw it, go for it. What I will say is that one of the dangers, it's kind of, I think, partially related to this. One of the dangers that a lot of people get into, a lot of my students get into, we're type A people that go into medicine. We want to know everything. We want to have the answer for everything. We want to be able to answer any answer choice that comes up. We want to know not only which one is right, but why the wrong ones are wrong. That's great when you're studying. When you're doing tutor mode, knowing why the wrong answers are wrong, fantastic. On test day, the only thing you're obligated to do, and this is really critical, the only thing you're obligated to do is pick that correct answer. So if you can't explain what answer choice D, it could be right if one or two things in the question stem were changed, and then you start playing with that, manipulating that in your mind. It's not worth your time. It's not worth your cognitive effort. If you see the correct answer, you thought of it before you even saw it, pick that answer, and then move on. And you don't have to, you're not obligated for the wrong answers. You're only obligated to pick the correct one.
Yeah, I tend to agree with you. So what I typically tell my students is, so I'll say that my advice depends on how much time you find you have at the end of a block, right? So if you feel like you have plenty of time, you're cruising, then, you know, take your time, go through these answer choices. What a lot of my students have told me they like to do, actually, and what I've tried as well, is you like to do this, if you see a question that you know right away, pick it, move on. Don't even look twice. If you see it, exactly as Dustin said, if it jumps into your head as soon as you see it, go for it, move on. But what I'll say is I try and tell most of my students to do a second pass through your question block, right? If you've got 40 questions, if you're able to get through them and you have like 10 minutes left at the end, when you're going back through, don't do that quick sort of glance again. Any questions that you glance at quickly, make sure you read them carefully to see that there wasn't something you missed in the question stem, because there have been many a time that I myself have done this and have found, oh, they actually put this in there. They were trying to get me to click really quickly, and you can catch yourself. So I think it's reasonable to do, particularly if you're tight on time. But if you have the time, go back, read everything quickly, and see that you're not missing anything big.
Yeah, you know, I like that you say that, like going and making a second pass. One of the really difficult problems to fix in yourself as a student is, am I switching from the correct answer to the wrong answer? That is a really hard problem to fix. It's almost, you know, it's very difficult. So my policy, and I have a policy, I think there is something to when you're between answer choice A and B, and in your gut, you're like, I'm 50-50. I can't pick between them. Answer choice A is what my gut told me. I'm picking it and moving on. Flag that question, come back and look at it. Under no circumstances do you change the answer from A to B. Do not talk yourself out of it. Leave it. The first answer you chose should be the answer you leave it, with the exception being if you find incontrovertible evidence that actually, oh, it was actually B. I misread this one line. It's actually B. If you find that, change it. If you read back through it again and you're equally as confused as the first time you went through, your first answer is it. It's locked in. Do not change it. I feel like there is a power in that gut instinct that can help you not change the correct answer to the wrong one. So.
Yeah, I think it actually touches on one of our other questions about two possibilities and what do you do when you're stuck. And I think that one thing that I really recommend is, again, this is all sort of in an ideal world where you have the time, right? So if you don't have time, go with your gut, move on. Another thing I like to sort of recommend is, if this were the right answer, what would have to be true? I try and do it in reverse. So if A is the right answer, what would have to be true? Is it too much of a leap? Would I need 5 other pieces of data for this to be true? Would they also have to be anemic with this type of anemia and this type of lab value? Do you have to do a little bit of bending over backwards to make it work? Versus for answer B, let's say it's much simpler. And it's well, most probably it's this, but it could be this. So really, how much has to be true that's not given to you, and sort of using that logic to, I found that sometimes can be helpful. But again, if you have time. If you don't have time, just like Dustin said, go with your gut.
Yeah, I like the way of looking at it backwards. The other thing I'll say, this is along with next best step in management questions, the other thing that haunts your nightmare as a step 2 or your nightmare as a step 2 student is you get down to the answer choices and you got 2 A and C 50-50. How do I pick between them? And this is a genuinely difficult problem. I will say you are only doing yourself a service if you get it to 50-50. If you're guessing between 50 and 50, that's a lot better than guessing a 20% chance out of 5 answer choices. So that's a big improvement. But when you're down to that 50-50 and you say, I know it's A or C, I cannot for the life of me pick between them. I really can't. It is 50-50 neck and neck. How do I fix this problem? When a question author sits down to write a question, they're assessing your knowledge on the subject. They have to give you enough data points in the question stem to reliably, for the majority of people taking that exam, they have to give you 1 data point more, so that reliably greater than 50% of people pick A over C.
Mm-hmm. Right.
Your goal, sometimes you can think about it backwards. I like that strategy. The other thing you can do, if you start from the top and you read down, you're looking for that data point. What is the data point that moves the needle 1% in favor of A over C? That's all you need. You need that 1 data point, and it has to be in there. A lot of times, and I've seen it myself, and I'm going through questions with students, and I get to that. I'm like, I'm A and C, I don't really know. Yeah. A lot of times, what I've seen, I think the question writers are trying to steer you towards what is epidemiologically the most common diagnosis.
Yeah.
And so in those cases, I say, if it's a horse, call it a horse. It's not a zebra. And so those are the cases. If you're really stuck between them, which one of those 2 things is more common? That would be my ad hoc solution to that. So
yeah, awesome. Well, I think that's most of what we have for questions today. And of course, if anyone has anything that they come up with later, we have all of our contact information here. Please feel free to reach out to us. And so the last question I'll ask you, Dustin, is sort of parting advice. What is your sort of general advice for these exams, big picture things that people should focus on before they sort of embark on their journey?
Yeah, that's a good question. I think the STEP exams, if you were to summarize them, they're really exams about pathology. And they're particularly exams about the pathology that affects the largest number of Americans. So cardiovascular disease, lung disease, neurologic disease, and stroke. And, routine obstetrical stuff that, most American families will have some contact with OB-GYN at some point. So really keeping it focused. I hate to use this term high yield, but, I think it still applies. Really thinking about what is really prevalent in the US population. Those are things you should focus your time on. And really at the end of the day, keep sight of the fact that, these are exams of pathology. They really are. Step 1 bent it a little bit. Even still, step 1 is a pathology exam. Step 2 and step 3 even more so. And so always think about, it's nice to be able to think about pathophysiology histologically, what does a Burkitt's look like versus a mantle cell lymphoma? That's great. But really focus on, like, especially step 2 and step 3, what is the pathology here? What is the process that as a physician I can treat, I can reverse, or I can ameliorate in some way. So I feel like having that focus as your North Star going through your studying, I think is really beneficial. So.
Absolutely, yeah. And sort of to echo a lot of what you just said, I think it's really, really important to keep that framework in mind, because all of these questions, these are very different exams from step 1, in that you're really going to have to use your clinical management. I mean, that's the whole point of these exams, or your clinical sort of acumen to determine where you go to next. And so use what you see on the rounds, use what you see in your question banks, but really use your common sense and say, does this person look sick? Okay, do I need to do something now? Do I have enough? Do I feel like I have enough, or am I just nervous and want to test something else just to be sure? And really try and just more and more questions, more and more vignettes will give you that confidence to say, okay, I know what I'm doing with, CHF management. I know what I'm doing with pneumonia. I know what I'm doing with like CKD. Really figuring out, just doing more and more of it, I think is the best way to prepare.
Completely agree.
All right. So with that, thank you all for joining us tonight. We are so happy to have had the opportunity to speak with you. Again, any questions, feel free to shoot them to us. Our contact information is here, but have a good night.
Thank you.